A review from the New England Journal of Medicine Journal Watch just recently came out about using zinc to treat acute COVID-19. And I think the reviewer really just missed the boat. And so, what I wanted to talk about today was using zinc for treatment of acute COVID-19. Hi, everyone. This is Dr. Danny, the multifamily MD. Typically, I make videos about wealth building, specifically with an emphasis on real estate, but I am a practicing full-time hospitalist, and this is a topic that I feel pretty strongly about, and I just wanted to make a video just give an overview of zinc and also talking a little bit about other treatment options for COVID, and specifically about a review article. And so what I'm going to do is I'm going to share my screen, and I am going to pull up this review article. So here is the article, and it's zinc for patients with COVID-19. It was just published pretty recently, Clinical Infectious Disease, which is a well-respected peer-reviewed article, and it was in November of 2022. So here is the summary from this reviewer. In a randomized blinded multi-center trial in Tunisia, oral zinc demonstrated a beneficial effect on COVID-19 progression, particularly in hospitalized patients with severe disease. And so, they go through and they say, we've been trying to find treatments for COVID for a long time, and some of these have not been confirmed in larger studies. And they specifically point out vitamin C, hydroxychloroquine. You could also add ivermectin to that list. And so now there's another trial about zinc. And so they basically did a randomized double-blind trial, and they gave people 15 days of oral zinc, 25 milligrams twice a day, or placebo, and they measured a bunch of specific outcomes. And then at 30 days, the primary composite outcome, ICU admission or death, occurred in 10.4% in the people who received zinc and 16.7% in the placebo group. And then they also go to say length of hospital stay was 3.5 days shorter in the zinc patients. And then the people who were not admitted to the hospital, so ambulatory just means I walked into the clinic and they diagnosed me with COVID, and they had a shorter duration of symptoms, but no reduction in need for hospital admission. And so this is where my trouble comes in, is this is his, editorialized comments. So he basically said that they included people that are hospitalized and ambulatory, makes it hard to, interpret, which I disagree with. And then they also said this study was done a little bit earlier when there were higher rates of death and ICU admission. And that's true, that's not happening as often. And then here he says, I'm not ready to recommend zinc for hospitalized patients with COVID-19. And I certainly would not recommend it in lieu of proven treatments for COVID-19 of any severity. But for patients or clinicians who wish to try zinc in addition to other recommended treatments, there's probably a little downside and now some scientific justification. And so, this is where I think there is a difference between how some doctors think about so-called alternative treatments. And, for me, there's treatments that work and treatments that don't work. And so the way I think about treatments of any sort is, what is the evidence that they work, and what is the potential downside? And so, on one hand, you have industry sponsored huge trials. So if you're looking for a small effect size, you might have to enroll 5,000 people, or some trials had 10,000 people. And so obviously, if you have a drug and you have a double-blinded randomized trial and there's 10,000 people in it, and it shows that there is a positive effect, well, great. On the other hand, if you have a case series of 5 patients that got better when you gave them vitamin C for the common cold, well, that's clearly not as good a level of evidence. And then there's a lot of in between. This study is in between. It enrolled about 500 people. It was randomized. It was placebo-controlled, double-blinded. And so it was a pretty good trial. And, what I think that, you need to weigh, and what I think a lot of doctors, and specifically, this doctor who did this review, Dr. Call, I think what a lot of people forget is that for every treatment, you need to think about what is the downside. And so, right now for COVID, we have Paxlovid, we have remdesivir, we have steroids, and those are prescription drugs. They clearly have side effects. And so the way I think about this is that the worse the side effects, the higher the level of evidence that I need to convince me to give that drug to a patient. And on the flip side, the lower the side effects and the less severe the side effects, the lower the quality of evidence that I think is really necessary. And, this is not like my own pet philosophy. This is something that I learned while I was training out at the University of Arizona in Tucson, which is, if you haven't been out there, it's a big hub for integrative medicine. And Dr. Weil was, one of the early teachers and family medicine doctors out there who helped get their program started. And so this was something that was taught to me by some of my attendings. And I think it just makes inherent sense, is that if a drug has bad side effects, you need higher level evidence. If the drug has hardly any side effects, or the supplement for that matter, or the herbal, or the trace metal has hardly any side effects, then you really you don't need the bar to be quite as high. And so let's just go through this paper. It's a long paper. I'm not going to bore you with everything. This is the abstract. And so basically says that they randomized 231 people to oral zinc, 239 people to placebo, and they gave it to them for 15 days. And the dose they gave was 25 milligrams twice a day. And here are the results. And so some of the patients were in the hospital, 280 were hospitalized, 190 were ambulatory, just means they're in the clinic. And then here's where the results are. ICU admission rates were 5.2% in the people that received zinc, 11.3% in those that did not. And then they did, they also did mortality. Mortality was 30 days. At 30 days was 6.5% in the zinc group and 9.2% in the placebo group. And then they did a combined outcome, and they basically went out of their way to say that there was no huge difference between different subgroups. Length of stay was shorter in the zinc group. So if you got admitted to the hospital, on average, the people that they gave zinc were there for 3.5 days less. So if that would mean be in the hospital for 10 days versus 6.5 days. And then their conclusion was, zinc works. And so this was just the introduction. And then this was the methods. And, one thing, and then they had a pretty good exclusion criteria. One of the big exclusion criteria was that if your symptoms started beyond 7 days, that you were excluded from this trial. And this is pretty typical for actually for all the COVID drugs, but then also for, other viruses like the influenza, common cold virus, rhinovirus. So what we know about viruses is that the sooner you start taking them, the better. And so if you're 8 days out, viral replication has probably already reached its peak. And, taking a drug that's going to slow down viral replication is just not going to help you very much. So the bottom line with that is the earlier you can start it, the better. And so that was that. And then they went through, and then they just said how they got to all the patients that they got to. And then they had 239 to zinc, 243 to placebo. And then you always lose a few people. What you need to look out for is if they exclude 20% here, that's a red flag when you're looking at studies. But they had a couple that were excluded for different reasons, or the patients just said, I don't want to be in the study. And so they lost a handful, which is very typical if you look at a lot of these. And then they just go through baseline characteristics. And these were pretty typical patients. They had typical comorbidities, average age was in the 50s. So nothing really to write home. And then this is a forest plot. This is basically a nice way to graphically look at how well did the intervention work. And so overall, if you're to the left of this line, you can be sure that it worked. If you cross the midline, it kind of questions whether it's statistically significant or if it's just within the margin of error. But overall, it worked. It did not cross the midline. The people who are admitted to the hospital, inpatients, they seem to benefit a lot. Outpatients, maybe not quite as much. And this is what I was talking about, time since onset, less than 3 days. So this is important. So if you started the drug within 3 days of symptom onset, you derived a lot more benefit. So the farther to the left on this curve, the box is basically the stronger the association. So if you took it within 3 days of symptom onset, you did better than greater than 3 days. So you see this one cross the midline. The older you are, the better they seem to do. The younger patients, less than 65, not quite as strong as association. And, to be honest, younger people with COVID in general get better no matter what we do. Male gender, female gender, not much. People with comorbidities seem to derive more benefit. So, that's not surprising. And so, what are some of the limitations of this study? This study was done in a country where the vaccination rate was not super high at the time of it. I believe it was around 23%. So that is one thing. And then, this is not really a limitation, but this is just something that happened, not for just with COVID treatments, but it's happened throughout the scientific community. But could it be that you get something terrible like what happened with ivermectin a year ago, where you had that guy, the researcher in Egypt, who faked a bunch of data? I think if you go around wondering whether all the data you're reading in a study is faked, you're not going to get anywhere. So you have to have some trust. But potentially that could happen. This was a big, this was a big to do back when this all first happened, because ivermectin was already under scrutiny, and then this guy faked data and just really, really just kind of made ivermectin look even worse. And to be honest, ivermectin probably does not work. I wanted it to work. I thought the mechanism of action made some sense. I actually took it prophylactically during the middle of the pandemic when I went to Disney, and I gave it to my family. In hindsight, probably wasn't the best move, but again, ivermectin, it is a prescription drug, but in the doses that people were taking it really was not going to hurt anybody. So anyway, that is about all I want to say about this. If you wanted to, read the whole study, you're certainly welcome to, and I will post a link to it in the show notes. And it's actually free you don't have to pay any money, which you do with a lot of journal articles. And so, what's the punchline? I work at the hospital. I see people with COVID day in and day out. Thankfully, not as much as I used to 2 years ago, and they're not as sick as they were 2 years ago. But what do I do for these people? So what I do is I risk stratify them. So if you are old and you're really sick, then I go through in my head and I say, okay, are you going to benefit from steroids? Would you benefit from Paxlovid or remdesivir? And then you also have to look at, are medications where it's going to be a problem to put you on one of those drugs? So if you're diabetic and I put you on steroids, it's going to make your blood sugar go crazy. If you are on, a statin or a bunch of antipsychotics, or, frankly, a whole bunch of other meds for Paxlovid, it interferes with, it interacts with almost everything. So that's a big problem with Paxlovid. Last week when I was at the hospital, I was going to provide Paxlovid for a patient, but he was on too many drugs that interacted with it. So I ended up putting him on zinc instead. And, he got better 3 days later. He was relatively young. So was he going to get better no matter what? Maybe. But there's, like I was saying earlier, there's very little downside. And the other practice that I do that I think that this reviewer missed is that why not add on zinc to your treatments? There's almost no downside. So I put everyone in the hospital who has COVID on zinc, which has some good evidence. Vitamin D, the evidence is not as much. Vitamin C, I also use that, but again, the evidence is not as great. But there's very little downside. So even if I'm going to treat someone with remdesivir and steroids, or Paxlovid and steroids, or maybe just Paxlovid alone, I'm still going to put them on the zinc, because I think there's so little downside. And one other question that you might have is, why does zinc work? And the truth of that is that no one really knows. You can look it up, and I've tried to figure this out. And that basically, at the end of the day, there's a ton of theories, but nobody knows for sure why zinc works. And that may sound frustrating to a lot of you, but the truth is, that is the way it is with a lot of drugs we have. We don't like to admit that to ourselves, but a lot of drugs, we don't totally understand why they work. We just know they do work, and that's fine for me. I'm a pragmatist. If it works, it works, and take it. One other thing that I should talk about is zinc toxicity. So this is from the NIH, and this is talking about zinc toxicity. And if you remember, I believe it was probably maybe 5 years ago now, there was a big scare about zinc causing people to lose their sense of smell. So that's called anosmia. And that was from intranasal zinc. So I believe that is completely off the market. I haven't seen that. So that was the Zicam that people are putting in their nose. And that was because of the method of delivery. It was somehow destroying basically your sense of smell neurons. And so we're not doing that anymore. People aren't losing their sense of smell. But if you go nuts with it and you take it all the time, these are the symptoms: nausea, vomiting, epigastric pain, lethargy, fatigue. But basically, it's very hard to overdose on zinc unless you are taking it every day at high doses. So I do not recommend taking zinc every day for prophylaxis. They've actually looked into this, and there's very little evidence that it helps you prevent you from getting colds, or COVID or whatever. But there's very good evidence that if you take it early in the disease course. So right now I actually have a cold. So, as soon as I realized I had a cold, I started taking zinc, and I'm going to continue to take it probably, if I was doing this by the book, I'd probably take it for 2 weeks. I usually end up taking it for a week or until I feel better. But the right dose for this, is about 50 milligrams a day. You could probably take 100 milligrams a day and you'd be fine. The only way you're really going to get toxic is if you're taking, 200 milligrams a day indefinitely. And to put that in perspective, you have a total of 2 grams of zinc in your entire body. So if you're taking 200 milligrams, you're not going to absorb all of it, for one, but just pretend you absorbed 100% of it. You could double your whole body's zinc in 10 days, but your gut and your body is too smart for that. It won't let you absorb it all. But you get my point, is that you only have 2,000 milligrams total in your body. So there's just doesn't make any sense to take these crazy high doses for that long a time. So the other thing I wanted to add is, if you do start taking zinc, I would suggest you not do it on an empty stomach. I have made that mistake, and I actually continue to make that mistake sometimes. It's been a while, it makes me nauseous. I get cramps. And I'm not the only one. My wife, other family members have told me the same thing. So I would suggest taking it with food. And it is hopefully will help shorten the duration of your COVID, or for that matter, if you have a common cold, it's been shown to help shorten the duration for that. But again, just make sure you're not going crazy on the dose. Go on Amazon. This is 100 milligrams. I think that's too high, to be honest. If you look up zinc supplements, you're going to find, I actually had a hard time finding 25. And if you look through that study, you'll see it's like something only made in Tunisia. But Here's one that's 30. That's pretty close. This one's 50. So, and there's nothing magical about taking it twice a day that I know of. So if you wanted to take 50 milligrams once a day instead of 25 twice a day, I think that would be fine. So that is all I really wanted to talk about today. Thank you for your time. Again, this is Dr. Danny, the multifamily MD, taking a little break from wealth building and talking about clinical medicine. If you found this information valuable, feel free to give it a thumbs up and share. If you have any questions or comments, put them in the comments below, and I'll do my best to get back to you. And have a great rest of your day. Bye-bye.